So, hello everyone, and welcome to this webinar today, Transforming Vaccination Globally, Regionally and Nationally, Accelerating Equity, Access and Sustainability through Policy Development and Implementation. I hope that you're keeping well and staying safe. And again, welcome to this really important webinar. We really do have some extremely qualified and outstanding speakers today. So thank you for joining this webinar. I'd also like to point out that all of the attendees today will receive a certificate of attendance. So next slide, please. So it's my great pleasure to be the moderator for today. My name is Tim Chen. I'm the Head of Pharmacy Practice and Health Services Research at the University of Sydney. I'm also the President of the Social and Administrative Pharmacy section of the FIP. Next slide, please. So just some housekeeping announcements for everyone to be aware of. This webinar is being recorded and live streamed via YouTube. The recording will be available on the FIP website, events.fip.org. You may ask questions using the Q&A box provided. So note at the bottom of your screen, you'll have a Q&A box and a chat function box. Please use the Q&A box for your questions. You are welcome to provide feedback to the address webinars@fip.org. This is a very important learning for FIP to receive your feedback. And of course, if you're not already a member of FIP, and you wish to become a member of FIP, please consider joining at this web address here. Next slide, please. So the FIP Transforming Vaccination Globally and Regionally program delivered in 2020 was the first digital transformation program which culminated in a global summit and the FIP action on improving vaccination coverage through pharmacies, as well as a digital collection on transforming vaccination. Next slide, please. In 2021, FIP is renewing its partnership with Pfizer and is launching its second program that focuses more on the equity and sustainability of vaccinations. Building on the outcomes of the 2020 program, the FIP 2021 digital program focus on supporting FIP members in accelerating programs of equity, access and sustainability of vaccinations through policy development and implementation, and through 2 series with a total of 12 events. So next slide, please. So the first of the 2 series comprises 5 episodes, which include today's opening event alongside 4 other events, which explore equity in vaccinations across different angles of age, gender, literacy and education, and collaboration and working together. Next slide, please. And the second of the 2 series in 2021 comprises 7 digital events, including 6 regional roundtables, which will discuss and identify priorities for sustainable access to vaccinations through pharmacies around the world. And this program will end with a leadership summit in which we present a commitment to action on sustainable and equitable access to vaccines through pharmacies. Next slide, please. And so the key outcomes for this Transformation Vaccination 2021 are, firstly, 12 digital events, including 6 regional roundtables and a leadership summit. Secondly, the FIP global commitment to accelerate equity, access and sustainability of vaccinations. And thirdly, a special policy collection. Next slide, please. And so today it's my very great pleasure to be the moderator and chair this session and introduce each of our speakers. And so next slide, please. The first speaker I would like to introduce is Dr. Regis Valencia, a long-standing FIP colleague. Now, Regis is currently a pharmacy consultant. Up until recently, he was the Director of Pharmacy of the Children's Hospital of Eastern Ontario. Throughout his career, Regis has served on multiple pharmacy organisations and boards, including the Order of Pharmaciens du Québec, the National Association of Pharmacy Regulatory Authorities. Regis has been an FIP Vice President. He's been the President of the Canadian Society of Hospital Pharmacists. He's been an Associate Editor of the Canadian Journal of Hospital Pharmacy. He was the President of the Ontario College of Pharmacists, and he's been a Fellow of FIP with the Canadian Society of Hospital Pharmacists and the Order of Pharmacists of Quebec as well. In addition to all of this, Regis is the author and co-author of more than 100 peer-reviewed articles. Regis, thank you very much for sharing your expertise today. We look forward to hearing your presentation. The floor is yours. Thank you.
Thank you for inviting me to this, sir. Thank you for inviting me to this presentation. Sorry, I have something that comes to my screen. Anyway, what I'm going to do today, and I'll give you a quick overview of some of the definition to basically anchor the discussion today about literacy, health literacy, and I'll bring in the concept of medication literacy, but I will not discuss it in much detail. Then I will talk about level health literacy in Canada and how we use this information to try to plan our vaccine implementation program within Ontario. I'll talk about the Ontario Plan. I had the privilege to be on the panel or the advisory group with the Premier of Ontario, which is one of our province, to look at how we will implement the vaccination program within our province. And I've been part of this group since December when it was formed. And I was the only pharmacist in this group with a group of physicians and all kinds of community leaders. I'll briefly go over vaccine hesitancy and some of the impact of it. And I'll finish my presentation of talking about some of the things we have done in Ontario to improve vaccinations. Next slide. So literacy. So we talked about, there's a concept of analphabet and the concept of literacy. Analphabet is you're unable to read because you haven't learned how to read. You're analphabet. Literacy is the capacity to be able to read or to write, the capacity for a person to read or to write a short statement in his everyday life. So the concept of literacy. Next slide. Concept of health literacy is another concept within literacy, is the degree to which individual can obtain, process, understand, and communicate about health-related information needed to make informed health decisions. So the concept is really that goes down from literacy, which is broader, to health literacy. And the next slide, please. The medication literacy is the same concept, but it goes right into how to manage your medication. And in some way, medication literacy is also a concept of vaccine acceptance or vaccine hesitancy. Next slide. So to better illustrate this, so we see this diagram. So literacy is a global concept. Health literacy is a concept within literacy. So to be able to manage health literacy, you need to be able to read and to write. And medication literacy is a concept within the health literacy concept. Next slide. So the way we look at the vaccination program in Ontario, we try to look at different aspects of it. One of the aspects of it was the health literacy of our populations. If you look at this, the health literacy could be divided in 4 segments: inadequate, adequate, intermediate, or skilled. And what you see on the right of the screen right now is the different group or health literacy by subpopulations. So we know that the people over the age of 65 have a very low level or inadequate level of health literacy. We also know that the new immigrants have lower literacy or health literacy, not because they might not be able to read or to write in their own language, might be because they don't speak the language of Canada, which is French or English. We also know as well that the new immigrants, or as I said that, they're also people that are working. Let's go to the next slide. This is the next slide, another way to illustrate the same concept. So basically the people that are have low health literacy are the people that are basically older don't speak the official language, and they're also unemployed. The next page, next slide. So health literacy leads, why is it important to look at health literacy? Well, it makes sense that it will probably lead to the fact that people will not want to get the vaccine. And if you're more literate you are, the more likely you get to be vaccinated because you understand the information that's provided to you. If you have low health literacy, you're more susceptible to false information and to the false news. And I'll do have a slide about false news later on. And make it also harder for them to make decisions. Next slide. I want to show this slide to show that in Ontario, the way we implemented the vaccination program, we did not see the effect of the age as a factor for vaccine hesitation. If you look at this, what we are seeing right now, and I will go over some of our implementation plan, is that look at the 80 years and older, about 93% of that group got 2 doses of the vaccine. So it's not the health literacy, it's not this group that we want to target. But if you go down and look at the statistics, the group that's most hesitant about the vaccine are the 18 to about 39 years old, which have the lowest rate of vaccination in Ontario right now. Of note in this graphic is the 12 to 17. We started very late to vaccinate them. That's why the rate of vaccination is a bit lower. Now let's go over the vaccination plan. Next slide. This is just a graphic to show you quickly how we did it. We did it in 3 phases. Phase 1 was a high-risk population grouping. Phase 2 was a mass delivery grouping, and phase 3 is steady state. I have the other slide to explain this more in detail. Next slide. So high-risk population, I think most countries end up using that approach. So we want to congregate living for seniors because our death rate was much higher as many countries in the senior group. We vaccinated healthcare workers to protect them, also to protect their patients. Adults of First Nation, Métis, and Inuit. The Aboriginal people are known to have a much lower, the First Nation in Canada have the worst health in the country. Their life expectancy is much shorter. And also they live in an isolated area. If they get sick, they don't have access to care. So they were prioritized upfront for the vaccination program altogether in Ontario. And age of 18 older. What's important to see here is the impact of pharmacy. So at that point, we started to have some pharmacy giving some vaccine, but we also implemented a program to allow pharmacy technician, licensed pharmacy technician, to give the vaccine as well, to enable the pharmacy to be most efficient when the next phase of the program. Next slide. So then phase 2 was mass delivery of vaccines. We have this big vaccination clinic run by public health. We also look at providing vaccine in pharmacy, but we focus in the pharmacy that were the hotspot area. And we discovered the hotspot area are the area where are the new immigrants. The people live in like 2 or 3 families in the same household, or the lower employed jobs. So that these pharmacies are the ones that got the vaccine to improve access. Next slide. And now we're going to the steady state. So where pharmacies, again, play a key role. All pharmacies that wants to give the COVID-19 vaccine are allowed to get some. So as the physician, their office. Of importance to see here is the pharmacy probably were able to vaccinate patients probably about 3 or 4 months before family physician were able to get the vaccine. The reason there was much less wastage in pharmacy of the vaccine than there would be in the family physician. Next slide. So what we've seen over time, and this is the graph of the number of vaccine available in gray, I would say, and the number of vaccine administered. And what we saw over time as of July came up is that we have much more supply of vaccine than vaccine that we can administer. And that brings into vaccine hesitancy approach that we're dealing with. Next slide. So we knew from the beginning that there would be some group of people that would accept the vaccine. There'll be some strangler that would basically be hesitant about the vaccine and they would maybe refusing it. They want to wait. And there will be some people that will completely refuse the vaccine. Next slide. So I'll give you a definition of WHO: delay in acceptance or refusal of vaccine despite availability of the vaccination service. related to fake news. So it's known that people with low literacy or low health literacy are more likely to listen and to believe in fake news. Vaccination reluctance, do not want to get their vaccine. Sorry, I'm just getting lost. So what we know as well is that vaccine hesitancy is quite significant across the world. And there's some data from the WHO looks at the vaccine hesitancy between 10 to 45% depending on the country. Next slide. So there's been a lot of fake news, a lot of comprehensive, a lot of information about the vaccine, and they would fed the anti-vaxxer, we're calling it anti-vaxxer in Canada. And what's interesting about this slide, I won't go into detail about this slide, but I want to tell you that in Ontario, my province, as a college of pharmacists, which is the regulatory body, if a pharmacist, a licensed pharmacist or a pharmacy technician was an anti-vaxxer, so we'll go on social media and talk about anti-vaccine or basically promote this conspiracy issue, he will be brought in front of the college in discipline, because our part of our college requirement is to use science to provide care, and it's not based on science. So the college even had the standing that if you're a professional, you should be using professional information to provide patient information. Next slide. Okay, the impact of vaccine hesitancy is basically, and we are seeing it here in Canada right now. Right now, we have a phase 4, I guess, of a wave 4 of COVID infection. And what we are seeing, despite that about 75% of the population being vaccinated, is that people that are coming to the hospital are the people that are not vaccinated. About 85% of people are not vaccinated at all. Another 10 to 12% are people that are not fully vaccinated. And maybe a small percentage, maybe 1 or 2% are vaccinated that could come in. So the hesitancy, basically what it does is protect the people and having this herd immunity altogether, and make it more likely for the older people, the people with other medical issues to get infected. Next. We also did a study to confirm, going back to the first concept, who was more likely to be hesitant in Canada about getting a vaccine. And what we saw is a racialized community. And here it's basically the Black community. Their likelihood of getting vaccinated was much lower than the rest of the Canadian. Therefore, we targeted a different approach to improve vaccination in this group. Next slide. We've targeted the healthcare providers. We want to make sure that the healthcare providers, every interaction with healthcare providers, will support the use of the vaccine. And there's a lot of education that came forward from our colleges of pharmacists, the pharmacy, to make sure that the pharmacy or the pharmacist, the pharmacy technician can talk positively about the vaccine. So, but however, despite this, next slide, we still know there's about 10% of the healthcare providers in my province, in Ontario, that did not get their vaccine yet. They're still concerned about side effects, the safety of it, but it works well. Still people do not trust the government. What we are doing right now, what we have seen as well, is that people with lower educational healthcare workers are more likely not to get vaccinated than the highly educated people that are healthcare workers. Next slide. So this is the approach we have been taking over time for our vaccination. At the beginning, we enrolled the community leaders. We enrolled the priest, whoever the leaders in the community, to get vaccinated publicly and to share within their community to try to draw them in, to draw the other people in. We brought the vaccine to the people. That's why we mentioned at the beginning that the hotspot area, which were the people, the most immigrant, which was mainly in Toronto, we had the pharmacy open 24 hours a day to give the vaccine so people can walk in at any time. We went to churches, we went to workplace. We had some place, the big workplace, Amazon, and if you know about Amazon, there's a big warehouse, it was right there to vaccinate. We want to give as much convenience as possible. We also lately went to the beaches or the attraction park, where the younger people go to make sure that we give them access to the vaccine. We involve primary care providers. As I said, we got trained to talk about the vaccine. The approach is not, do you want to get vaccinated? The approach is, when are you getting vaccinated, so that we make it clear that we expect the people to get vaccinated. We even have a program right now where a family physician have a list of their patients, and they know which patient did not get vaccinated, and they get paid to call these patients one-on-one with their secretary to ask them when they can come in to get their vaccine. Of course, like other countries, we have media campaign. We also provided a relaxed quarantine restrictions for those vaccinated. Right now, if you are not vaccinated and you get exposed to a patient that have COVID, then you have to quarantine for 14 days. But if you are vaccinated, if you have no symptom, you don't need to quarantine. So it makes it very more convenient. And just recently, we implemented compulsory vaccination for hospital workers. They need to vaccinate long-term care workers, education workers, school. And the reasoning behind here is that the people below the age of 12 cannot be vaccinated. They're not candidates for the vaccine. Therefore, we need to protect the environment as much as possible. A lot of university and school are requiring a full vaccination before the student can come on campus as well. Some provinces have implemented immunity passport as well. Not allowed to go to a theater to watch the movie or to go to a restaurant if you're not fully vaccinated. So it makes it to improve or to increase the willingness to get vaccinated. And a couple of provinces have if you get 2 doses of vaccine, your weekly draw you could win $250,000 Canadian. And the last draw in September, at the end of September, will be $1 million. If you automatically get into this lottery, the vaccine lottery, as we call it, remote vaccination. Next slide. This is a status as of last week, basically the Canadian status. So we have about 82% of the people that are candidate to receive the vaccine, 1 dose of vaccine, and including the total population, which is the children as well. We have 71%, 72% pretty much. And if you look at the fully vaccinated, we have about 72% of the 12 and older, and 63 or 64% of the populations. So we are getting there. We are aiming at 90% of the 12 and older to be vaccinated to get the full herd immunity with the Delta variant. Next slide. Oh, my next slide was basically a picture, and that's been changed. So a picture of the Prime Minister of Canada getting a vaccine in a community pharmacy. So our community leader have been able to promote pharmacy vaccination altogether, and the implementation of having pharmacy technicians giving vaccine has been quite successful in Canada. Thank you.
Thank you very much, Regis, for a wonderful presentation. Starting off with the definition of literacy, and then health literacy, and then medication literacy, and then going on to describing in some detail the practical considerations for vaccination rollout in the province of Ontario. It's now my very great pleasure to introduce our second speaker today, also a long-standing colleague from the University of Sydney, Dr. Fiona Stanaway. So Fiona is a clinical epidemiologist who is passionate about the use of research to address unequal health outcomes in ethnic minority populations. Her work plays an important advocacy role in encouraging inclusion of those with limited English proficiency. Fiona is the convener of special interest groups in culturally and linguistically diverse older adults for the Australasian Association of Gerontology. And she's also co-convener of teaching special interest groups of the Australasian Epidemiological Association. Now, since the beginning of the pandemic, Fiona has been one of the most active academic media commentators on Australia's COVID-19 response. And notably, this includes a research letter she authored, which was cited by our Prime Minister, not the Canadian Prime Minister. She's written invited opinion pieces in newspapers. She's appeared on live Q&A sessions with the general public, and her media work has stemmed from her belief in the importance of high quality and accessible science communication in the pandemic response. Fiona, thank you so much for accepting the FIP invitation to present in this webinar, and the floor is yours. Thank you very much.
Thank you, Tim. So my talk is going to talk about the relationship between health literacy and vaccine hesitancy, building on some of the points that Regis has made in the previous presentation, and talk about how that leads to barriers to vaccination equity. Then I'm going to talk about some potential policy solutions, and finally, the role of pharmacists. And throughout, I'm going to talk about some examples from Sydney, Australia, where both Tim and I are from. Next slide, thank you. So I thought I would start off by talking about how health literacy fits into this 3C model of vaccine hesitancy developed by the WHO, which features complacency, confidence, and convenience. And although health literacy can relate to all three of these components, I'm going to concentrate more on the aspects of confidence and convenience today. So when we think about the element of confidence, that really refers to trust, and trust in vaccine efficacy and safety, as well as the health system and policymakers. And trust has a very important relationship with health literacy, both because if you've got low health literacy, that might influence your trust, say in the vaccine efficacy and safety, but also trusted relationships can be a really important way that we try to improve health literacy. And I'll be talking about that later in the presentation. In terms of convenience, we often think of convenience with the vaccine as having a convenient time and place to get the vaccine. But in this model, there's actually further aspects to it. And that includes the cultural context and having a cultural context that's comfortable for you to receive the vaccine. And although not exactly health literacy, as I'll talk about in this presentation, many people from diverse backgrounds in multicultural countries like Canada and Australia do often face, they do have an increased risk of having low health literacy as well. And that often combines to create barriers to vaccination. And also there's an importance in terms of convenience in being able to understand the information you've been provided with. And that includes both having information in a language that you're fluent in, as well as language that is simple enough for you to understand with your level of health literacy. Next slide, please. And these important aspects of communication and context and trust for COVID-19 vaccination have been outlined in this new proposed now 5Cs model, where they've added the word trust to the element of confidence, and they've added these two new components of communication and context. And so when I'm talking about some of the barriers to vaccination equity, I'm going to really focus on these two components of communication and context and how that relates to health literacy. Next slide, please. So in terms of communication first, so there's often limited attention that's paid to the needs of people with low health literacy in information campaigns, including for COVID-19. And it's really important to consider the needs of people with low health literacy because they're more likely to endorse and believe misinformation, and as a result have reservations about getting vaccinated. It's recommended that health information is pitched at about a grade 8 or lower level of reading. However, some recent research looking at information provided in Australia and New Zealand and some other countries and in official government websites found that in fact a lot was pitched at a higher reading level. So it was too complicated, didn't use enough simple languages and not a simple language and not enough images or graphical elements in combination with the text. And worryingly, it was information about vaccines that seemed to be the worst. So that was pitched at a higher level than the information about masks and physical distancing, which was simpler. And another finding was that there was no clear action points or steps for people to take. So after reading the information, there wasn't really any clear indication of what people needed to do. Next slide, please. In terms of context, this is another really important barrier to vaccination equity related to health literacy, and is particularly relevant in multicultural countries like Australia, and it often refers to barriers faced by ethnic minority communities. And these might include a combination of lower health literacy, low English literacy or literacy in the dominant language, and sometimes even a lack of literacy in their own language. And this can mean that it can be difficult for different ethnic minority populations to access government website information, to understand it, and even sometimes when that information is translated. I think it's important to note that there's a lot of difference between different ethnic minority communities, and there's been some interesting research just recently in Sydney looking at some of the differences in sources of information by different language and cultural groups. And so, for example, they found that more than 90% of Khmer speakers, predominantly from Cambodia, used government and official sources of information, whereas in contrast, less than 30% of Samoan or Tongan speakers used official sources to get their information. And Chinese speakers, at least 50%, just over 50%, used WeChat to get information about COVID-19. So a lot of differences between different ethnic groups in terms of where they're getting the information from. But overall, their finding was that people speaking a language other than English at home were less likely to use the official resources than the majority population, and more likely to get information from Facebook and other social media, their friends and family, or from their community. And this is important because this can sometimes mean that they're more likely to be exposed to misinformation. And if they have low health literacy, they're more likely to believe that misinformation, and that can translate into lower vaccination rates. Next slide, please. And this is an example of how this has played out in Sydney, where at the moment we're experiencing an outbreak. And here are two maps of Sydney showing the vaccination rates in different suburbs across Sydney and how that's been changing from the 9th of July to the 23rd of August. And you can see that in the centre of the map that vaccination rates are much lower than other parts of Sydney. And these are areas of Sydney where a lot of migrants live, and a lot of the population speak a language other than English at home. And that's not the only reason why vaccination rates are lower in these suburbs, but it is an important contributing factor. Next slide, please. So what are some of the policy solutions to these barriers that arise through problems with communication and context related to health literacy? So these are two recommendations that are taken from the framework for equitable allocation of COVID-19 vaccine produced by the National Academies of Sciences, Engineering and Medicine last year. And I think they speak really well to both of the issues of communication and context. So the first one is around appropriately funding a vaccine risk communication and community engagement program. And I think it's that community engagement part that's particularly important. And this recommendation involves an emphasis on two-way communication, so finding out about the information gaps and misinformation in specific communities, and then having a targeted approach and partnering with the communities so that different diverse populations are reached. And then in the second recommendation, where they're talking about developing and launching a vaccine promotion campaign, again, there's this emphasis on partnering with community stakeholders so that vulnerable communities can be reached. And that's particularly important where there's higher vaccine hesitancy and lower health literacy. And again, they're emphasizing the importance of having messaging in a lot of different languages, and including graphical elements and key action points, which are important for people with low health literacy. So finally, how pharmacists can contribute. So I thought I'd come back again to this 3C model of complacency, confidence, and convenience. And I think when we think of the role of pharmacists, we often think of convenience and how they're open extended hours, they're available in multiple locations. And I think that is a really important aspect of how pharmacists can contribute to vaccination. But I think another really important aspect is the concept of trust, which is tied to confidence. And pharmacists are trusted health professionals, and they're often trusted members of the community. And as I mentioned at the beginning of the talk, it seems that trust is a very important aspect when we're dealing with people that have lower health literacy. And it's been found that when people with low health literacy are interacting with someone whom they have a trusted relationship with, they're more likely to listen. It's more likely to have a positive impact on their health literacy, and therefore more likely to change their behaviour around vaccination. Last slide, please. And so I thought I would finish on this good news story, which was reported in a Sydney newspaper a couple of weeks ago about a pharmacist, and I think highlights many of these points around trust, communication and context that I've been talking about over the last sort of 10 minutes. And so the picture on the right is of a pharmacist in Western Sydney, in one of the suburbs that I'd highlighted on the previous slide as having a lower rate of vaccination. And this pharmacist has managed to vaccinate 10% of the residents of her suburb within just 1 week. And many of the quotes that she has made in this article, I think, reinforce why she's been so successful. So, for example, her first comment, she's talking about how many of the people in that suburb have had very negative interactions with government services. So they're not trusting government and health services, but yet they see the pharmacy as a place that they can trust. She also talks about how she has a refugee background and that that many of her customers are also refugees. So she has the cultural competence to be able to access and work with this vulnerable population. And finally, she mentions about how difficult it can be from people from different cultural backgrounds in her suburb to be able to navigate the complex system that has been rolled out to the general population. So I think in conclusion, health literacy has a really important aspect on impact on vaccination hesitancy, and then and as a result, vaccination equity. And pharmacists have a really important role to play in that through both trust and as well as convenience, and being able to break down many of the barriers around communication and context.
Thank you very much, Fiona, for a wonderful presentation and for highlighting the 3 Cs and also the 5 C model, especially in relation to confidence and the trust of healthcare professionals, pharmacists in particular, as both highly accessible or convenient healthcare professionals and highly trusted healthcare professionals as well. I really liked how you talked about the differences in strategies required for different ethnic groups as well. This is going to be super important in the rollout of the vaccination programs, whatever jurisdiction we're working in. So thank you for a wonderful presentation. So it's now my great pleasure to introduce our third speaker this evening, Professor Hanali Maya from South Africa. So Hanali is the head of the South African Vaccination and Immunisation Centre and Program Coordinator of the Master of Pharmacy in Public Health, Pharmacy Management in the School of Pharmacy at Sefako Magotho Health Sciences University. She specialises in vaccination safety, antimicrobial stewardship, vaccine hesitancy, and rational use of medicines. Her research aims to strengthen healthcare services, improve public health, and contribute towards reaching the sustainable development goals of good health and well-being. Now, Hanali also chairs the Ministerial Advisory National Immunisation Safety and Expert Committee, and because of this, she's a member of the South African National Advisory Group on Immunisation. Hanali also serves on the National Technical Working Group for COVID-19 vaccine and is the co-lead for COVID-19 vaccine safety and surveillance for the National Department of Health in South Africa. She also co-chairs the African Union Smart Safety Solution Joint Signal Management Group, aimed at facilitating cross-country signal management for COVID-19 vaccines in Africa. So we have an extremely well-qualified presenter to talk to us this evening. Hanali, the floor is yours. Thank you very much.
Thank you very much for that nice introduction, and yes, for the opportunity to present here today. So my presentation, I will first, excuse me, I will first look at vaccine hesitancy and health literacy and how they relate to one another. Then I'll go on to the enablers and barriers to in health policies and what we can do to actually increase vaccination inequities. Then I will move on to also what the role of the pharmacist is in contributing to this agenda. And then lastly, what important policy change can take place to reduce vaccination inequity. So with regards to the, my colleagues has already now alluded to a lot of, in terms of vaccine hesitancy and health literacy. But just to emphasize, if we look at health literacy and vaccine hesitancy and how they impact on one another in terms of access to vaccination, we know vaccine hesitancy is defined as a delay in acceptance or refusal of vaccines, except the fact that the vaccine services are available. And it ranges, as you can see here, from delaying vaccination to refusing vaccination. And it's a very context and vaccine specific phenomenon. So it's also, like previous speakers alluded to, influenced by these factors such as confidence, convenience, and complacency. So with the rollout of COVID-19, vaccine hesitancy has really become a very hot topic of discussion. However, already in January of 2019, the World Health Organization declared vaccine hesitancy as one of the top 10 threats to global health. Next slide, please. So if we look at health literacy, we've heard now that it's a very complex concept with multiple features. And it's about it's all about the ability of people to use health information for decision-making about their health in their everyday life. So there are many determinants of a well-functioning health system, of which people is one of the most important ones. So the importance of health literacy comes in where you have a better relationship between the people and the healthcare system. So we also know that health literacy is independently associated with worse outcomes in terms of health, and that it influences people's ability to engage with preventative activities. And those are very important for infectious diseases, as we are using vaccines to prevent these infectious diseases. Next slide, please. So now, just to recap on vaccine literacy itself, it is much more than just knowledge about vaccines. And I mean, vaccines are very complex, and the information around them is very complex and difficult for people to understand. So it requires literacy and numeracy skills, critical thinking, and evaluation skills. So health literacy, and specifically vaccine literacy, is therefore a determinant of vaccine hesitancy. Next slide, please. So just to add on to what Fiona has already said, so if we look at acceptance of childhood vaccination, the more recent researchers then suggest that we add another two aspects in terms of these drivers of vaccine hesitancy, of which the one is calculation, which is about seeking information and then weighing the benefits against the risks, and then collective responsibility, which is all about understanding the value of vaccination in creating herd immunity. So research has also shown that a person's own worldview also has an influence on vaccine hesitancy, with neoliberals believing that individuals must assess their own health-related risks and then make their own health-related decisions. So this worldview is also often in conflict, and we've seen it so much in the media, with vaccine promotion images, which tend to be informed by other discourses such as generalized risk and safety, statistics, and asking people to trust authorities and follow what they promote. So on the other hand, those experiencing social exclusion, whether it's now economically, socially, or politically, they may lack trust in the government and therefore feel alienated, resentful, frustrated, and demotivated. Next slide, please. Now, if we return back to the healthcare system, the most important ingredient in all vaccines is trust. So there are many reasons, as you've already heard, for distrust, which varies across time and place. So research has definitely shown that the healthcare system distrust and low health literacy were the most important drivers of vaccine hesitancy. So these findings suggest that health literacy can be used to mediate the relationship between the healthcare system distrust, which is so important, and vaccine hesitancy. Next slide, please. So what are people's concerns when it comes to willingness to vaccinate? And where do they get this information from? Now, during the COVID pandemic, there's been various surveys globally as well as in South Africa. And here you can just see an example of one of the latest surveys, the NetScram Wave 5 survey, which was conducted in South Africa, where respondents who indicated that they are not willing to take the vaccine were asked why. And most of them were actually believing that vaccines were not adequately tested. They had concerns about the side effects and the safety of the vaccines. So in terms of these sources of information, as you can see there, users of social media were more likely to be low in vaccine acceptance. Next slide, please. Social media allows for easy mass public communication. And this recent study actually found that social media is very strongly associated with the perceptions that vaccines are unsafe. So vaccine hesitancy is not new, it's not a new concept, but it has really, social media has really pushed it into a new level. So although social media allows for easy mass public communication, it also allows for opinions and disinformation to be shared widely. And any opinion can be presented as a fact. And it's difficult for individuals to differentiate between whether something is an established fact or not. Subsequently, the real truth then gets lost in all this noise. And then uncertainty leads to vaccine hesitancy. Next slide, please. So we know that the use of technology provides multiple opportunities for accessing information. And we've also seen it now during the COVID-19 pandemic. So, however, there's always a group, and in some cases, large sectors of the population not having access to technology or having low literacy in terms of technology. Especially if we look at the elderly, they could, for example, not have access to a cell phone or to data, or some of them might have access, but they have poor eyesight, they cannot read the numbers, and they cannot type. So here you can see in South Africa some examples where they changed the guidelines and protocols, and they are using volunteers and young people to actually help in mobilizing the rollout. Also, they use certain methods in taking the vaccines to suitable locations, such as pension payout points, where people can then access the vaccines and obtain information. Next slide, please. So policies and guidelines should address heavy reliance on technology as a means of access to vaccination. So this requires a very clear communication strategy and social mobilization. So language is very important, as well as geographical accessibility, and there are various ways to overcome that. An innovative intervention is also to involve those, vulnerable groups in the design of technology to determine, what is their capacity, what are their needs, and what are their limitations. Next slide, please. So here you can see some examples of policy and guideline changes that took place in South Africa to address issues of health literacy impacting on access to vaccination. So our most rural province, the Limpopo province, they have been very successful in reaching out to these vulnerable groups. And there's also now a health train launched by Transnet, which will be used to take vaccines to remote communities and those with limited medical resources. Next slide, please. So in South Africa and I'm sure also in many other countries across the world, immunization services have always been, primary healthcare driven. So on the one hand, you have healthcare workers with vast experience in terms of the practical administration of vaccination, while on the other hand, you have all these experts and academics with vast theoretical knowledge about vaccinology. And in the middle, we have vaccine hesitancy and people being uncertain with low confidence in vaccination. So the question is, what can we do to actually bridge this gap and empower vaccinators with the necessary knowledge, skills, and confidence to be able to address these challenges of vaccine hesitancy and health literacy? Next slide, please. So in South Africa, the pharmacy profession has really contributed significantly to the immunization agenda, and I would say thanks to COVID-19. So as a result of policy changes now during 2021 and collaborations with our National Department of Health, our Pharmacy Council is now playing a very instrumental role. And this is going from registration of the vaccination sites, with all vaccinators now being required to have a permit in terms of the legislation. So one of the requirements, as you can see on the screen, is the provision of, is required training should you want to provide vaccination services. And one of the modules that's required in the training is focusing specifically on communication with the community about COVID-19 vaccination. Next slide, please. So here you can see more about the policy and regulatory changes in the pharmacy profession to ensure pharmacists are adequately trained and competent in providing immunization services within their scope of practice. So in terms of health literacy, where the pharmacist can play a very important role, two of the domains actually covers effective communication strategies on the risks and the benefits of vaccination, and thereby to build confidence and demand for vaccination. Next slide, please. So how can pharmacists then make a difference within the community setting in terms of health literacy? So research has shown that motivational interviewing is much more effective than didactic communication. So in essence, it's a paradigm shift from an approach where you talk to and you tell the person to a more collaborative working with the person style of communication. So with this approach, the person's internal motivation to change is enhanced while exploring and resolving their own hesitations. Next slide, please. So legislation has also been used in some countries to prohibit the spreading of false information. And this is an example from South Africa where spreading misinformation is a criminal offense. Next slide, please. So this is just more about this, an example from one of the provinces, the Western Cape, where the public is then encouraged to report fake news and at the same time also being given some tips on how to stay informed and shut down fake news. Next slide, please. So journalists play a very important role in the type of information that appears in the media and ultimately the literacy of the public out there. So while it's beneficial for them to report, a slightly skewed, poorly worded headline can result in confusion and uncertainty and fear amongst the public. Something to keep in mind is also press freedom. So in South Africa, journalists already raised concerns about the impact of the disaster management regulations in terms of spreading fake news on the right of freedom to expression in the country. So it's a challenge to find the perfect balance. Next slide, please. So it's important, to consider policy changes to reduce vaccine inequity with regards to health literacy. And this should include making it mandatory to include cross-cutting components in primary and secondary education in our schools. So this should include media literacy as well as information literacy. And then furthermore, also to make it mandatory for tertiary institutions to include public health education in all their health sciences, including pharmacy curricula, as well as in the journalism curricula. Next slide, please. So the take-home message from me is to bridge the gap is to empower all healthcare staff, not only pharmacists, but all healthcare staff in pharmacies and other healthcare settings. So staff who are knowledgeable about the science behind vaccination, they feel more empowered to promote vaccination with confidence. And this will increase public confidence in vaccination and increase vaccination uptake. So obtaining knowledge and keeping yourself up to date is key to creating a society in which people recognize the value of vaccination and demand it as a human right to themselves and their children. Thank you very much.
Thank you, Hanali, for a wonderful presentation and also for sharing your vast expertise of vaccine policy in South Africa. I really like how you added to the 5C model by including calculation with respect to risk and benefit, perhaps numbers needed to treat and numbers needed to harm in this context, and also the collective responsibility and the notion of herd immunity there. I also really like how you pitched the use of motivational interviewing in the context of community pharmacy, and then bridging the gap by breaking down knowledge, skills, and confidence between experts and people for whom these knowledge, skills, and confidence are needed. So thanks very much for an excellent presentation. It's now my very great pleasure to introduce our fourth speaker for this evening, Mr. Muhajid Hussain Valji. He is by profession a pharmacist, having completed his bachelor's degree in pharmacy at Muhimbili University of Health and Allied Sciences in Dar es Salaam in 2007. And he also has a master's qualification from Queen's University Belfast in clinical pharmacy. Now, Mujahid has been working at the Aga Khan Hospital in Dar es Salaam for the past 13 years, and he's currently the chief pharmacist of the health services in Tanzania at the Aga Khan Health Services. He's been part of the FIP Hospital Pharmacy Africa region section for the past 3 years, and he's also been coordinating the activities for the Africa region. We welcome you to the podium, and thank you very much for sharing your experience and expertise. Over to you.
Thank you, Timothy. Hi to all. I'll be briefly discussing on health literacy and in relation to vaccination hesitancy. What are the enablers and barriers to access to vaccines? Role of pharmacy and what pharmacy-based literacy can do to increase the rollout, and some important policy changes that can be made to increase access and equity to the vaccine rollout. To start with, just to remind all, I know this has been said by the first speaker about what health literacy means. is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. This is very important, that it should not just, the concept should not end just at obtaining, but rather processing and understanding the basic health information so that an informed decision can be made. So yeah, it is important to go beyond just obtaining information to process, which will help filter out misinformation and understand the rationale behind arriving at a decision, which in our case is whether to take or not the vaccines. And as said by the previous speaker, that the media, the social media, and the advocacy against vaccines is really confusing the people around, especially in a setting like Africa, where we have many, majority of the people who are not that literate. Next slide, please. A lot of health illiteracy is also a result of culture and faith, where people believe God is the rightful protector and nothing can harm an individual who has conviction. So yes, you might be illiterate, you might have gotten the information, but then some just have the belief. And in our setting, we had gone through this phase where even politically this vaccine was not acceptable. But thankfully, for the past 3-4 months, things have now changed, and now the vaccine rollout has been enhanced because of political willingness is now there. So as said earlier, it is a process of not validating information which leads to hesitancies and lack of confidence in what could ideally be the correct choice. Therefore, it is a domino effect which surprisingly is not only a result of layman's misunderstanding information, rather also healthcare professionals who do not responsibly validate and communicate the correct information to the public. It is vital for all healthcare professionals to be at par with ongoing trends in the medical field, since it is one that is evolving by the day. And as we shall see, the role of pharmacy in this, how we can play our role to educate the mass on the rollout of vaccine. Next slide, please. So what are the enablers and barriers in health policies which can increase access to the vaccines? Number one is a political willpower. For us, especially in Tanzania, this was a big challenge whereby the political willpower was not there because there was a denial on accepting the vaccine. But thankful now for the past 3 or 4 months, things have changed and there is a political will, and hence we have seen that there is the rollout has increased and now quite a number of people have already been vaccinated. Secondly is a freedom of speech in a controlled manner, whereby, and that's where the role of social media comes in, whereby we have, so the social media should be controlled in such a way in both extremes. As we know, this vaccine is a choice. It has to be the choice, the final choice is everyone has to decide for him or herself. But then there has to be the media outlet should not be there to confuse the people or misguide the people. So there should be a way of controlling the freedom of speech. We have to, the third point is encourage research and development. This has to be done at the academia level where in different settings, we should encourage R&D, and these data should be shared with the public, which will increase the confidence towards the rollout. This could even be when we are monitoring the monitoring the side effects of the drugs, when the pharmacovigilance data should even be shared with the public, which will help in reduce the fear that people have in relation to the side effects of these vaccines. Presence of support groups to address concerns of the people. So yes, we might convey the message to the people, but many of us do have some queries and do some have concerns in regard to the vaccines. So who do they refer to, or whom do they contact in such cases? So we should have support groups or contacts whereby people can contact to get their issues addressed. It could be through email, it could be through phone calls, it could be through visiting an office or a place where their concerns can be addressed. As I said, data collection and sharing to the public, and this data collection can be, let's say, in terms of hospitalization. For example, in our hospital, we have started collecting data on those who are admitted. How many of them are vaccinated and how many are not vaccinated? Those vaccinated, what has been their prognosis, or how have they been, where have they reached the discharge, or whether admitted into ICU? So all this data collection and sharing to the public will enhance their confidence and increase the compliance or the rollout. And then is to provide incentives to those vaccinated, right? So the incentives could be in different scenarios. For example, the issue of it could be the issue of, for example, those who are traveling. The quarantine. I hear some countries everyone put that those who are vaccinated, the quarantine time is reduced, or it's not there. So such incentives should be there for those who are for getting vaccinated. Like we saw in the previous slide, there is a lottery for those who are vaccinated. So such incentives even helps in getting more people vaccinated. Next slide, please. So now we come to what is the role of a pharmacy profession in this field. As we all know, pharmacists are well positioned to increase awareness about the vaccines, as they are trusted and most often the first point of contact. Especially in our setting, many people first start off with the pharmacist before going to the doctors. So if we pharmacists are well acquainted, we ourselves are convinced, we are the best people to educate and convince people to go for the vaccines. However, it is very important to note that we ourselves need to be well educated and convinced about the vaccines before embarking on educating others. So, for example, in our setting, the healthcare professionals themselves are not yet that convinced about the vaccines, and they're worried about the side effects and other hesitancy that they have, or the beliefs. So what we have decided as a Pharmaceutical Society of Tanzania is we will first bring about awareness amongst the pharmacists themselves, who will then, once they are convinced, then we will use them to go and convince the masses on this rollout of vaccines. So this brings about a very important point of educate the educators, so that they can be our voice towards this campaign. Another important thing that we feel is pharmacists should be part of the policy making team on vaccination. So when the vaccination policy are being made or decisions are made on the rollout, they should be part of the team which makes these policies and these decisions. Next slide, please. Okay, what are the pharmacy-based health literacy activities that can be carried out, which will increase the access and equitable access to the vaccines? So we have to make the relevant and acute information accessible to the public. We don't just have to dispense the information, rather make it understandable to the public and help them to make an informed decision, right? So we might have to talk at different levels to different people depending on their literacy level. Secondly is awareness campaigns that discuss mechanism of vaccine action in layman terms for people to understand the need for the vaccine, the manifestation of its side effects and statistics on effectiveness to counter the disease. Now these campaigns can be in different forms. So now as a country and as our rollout, we have now even are encouraged to do mobile campaigns and vaccinations, whereby we visit schools or companies, or where we can go educate them and vaccinate them there and there. Next slide, please. Current situation: no confidence in vaccine, and thus this needs to be restored by debunking the myths which are prevalent, as well as using influential figures who have taken the vaccines to relate to. So these are, again, how do we counteract the effects of the social media? So this is through through education and using public influential figures who could be political, religious, or those who are looked upon, so that we can use them to have the myths debunked and the right information conveyed. Provide information to people of local trials and tests done on vaccines. Again, these are the data that can be shared to the public so that they are made aware of the exact statistics on the vaccines. Brochures provided to all patients who come to the pharmacy. So as pharmacists, we dispense drugs, they always carry out, they carry home in a bag. So we can use brochures, or simply we can put some information of the vaccines on the bags that we dispense. Like when we dispense, most of the pharmacies, they write something on the paper or plastic bags about the pharmacy. So we could put some information about vaccines onto these bags so that the information is conveyed. Next slide, please. Again, counseling. Pharmacy counseling to both in and out patients based on have you taken the vaccine. This also entails understanding the hesitancy factors and addressing them appropriately. So this counseling has to be both ways, whereby we are conveying the message to the public, trying to convince them. On the other hand, let us even try to understand their concerns and address them accordingly. And then the other aspect that can be used is to educate people on how vaccines have helped eradicate or reduce diseases like polio. So these past vaccination data can even help in convincing people to increase the access to the vaccine. The other possible way is, especially those who come to the doctors or the hospitals, is to use the common diseases, right? And when counseling people, especially those who are at high risk, those with asthma, diabetes, hypertension, that they are at risk of this COVID-19, and hence taking the vaccine helps them in reducing risk and reducing the risk of severity of disease. Next slide, please. Okay. In conclusion, I would say the sources of health literacy are healthcare professionals, social media, and personal public convictions. It is important that people are educated to make an informed decision. That is, to whatever they hear from whatever the source, especially the social media, they have to think it through and then come to an informed decision. The pharmacy profession plays a vital role in influencing policies and carry out activities that can increase access to the vaccine. And one of the important policy change, which if implemented, is control of social media misinformation in ensuring that the correct message is given to the public so that informed decisions is made concerning the vaccine. Thank you.
Thank you very much, Mujahideen, for a wonderful presentation and for sharing your own experience from Tanzania. I really liked how you emphasized the importance of busting the myth of information provided on the social media and use of key opinion leaders to help change that paradigm. You also raised some very important considerations, including belief systems, culture and faith, and how this relates to vaccine hesitancy as well. And I particularly like the notion or the idea of train-the-trainer approach in pharmacy, whereby first training pharmacists and then train them to provide information to consumers. Now we have about 15 minutes for questions and comments. I'd like to invite all of our speakers back to the podium, and there've been quite a lot of really very good questions in the Q&A, and there's not been so much duplication of those questions, which is excellent. But the first question that I want to put to the panel is the notion of vaccine hesitancy. Is this related to a specific vaccine or not? And I guess as a bit of a related question, and given that we've had first wave, second wave, third wave, fourth waves of the pandemic, has health literacy changed over those first wave, second wave, third waves, and fourth waves, as there's been more information provided to the general public. So Regis or Fiona or Hanali or Mujahid, do you care to comment? Thanks, Regis.
The approach we've been taking in Canada is a bit different, meaning that we've been promoting a lot on social media, going back to the news, going back to the reporters, the media being so important, conveying the fact that the people, the fourth wave that are getting hospitalized are people that are not vaccinated as well. And we put a lot of emphasis on this one. So the issue is that addressing, and again, the Canadian approach has been like the lottery, the vaccine passport has been the quarantine, trying to find different ways to address this from looking at it from a convenience. They even went as far as we went as far as advertising. It's not a COVID vaccine. It's the going to the restaurant vaccine. It's going to the a social event vaccine, as opposed to it being a COVID vaccine. So we didn't focus on the type of vaccine. We focused about what can you get if you get benefit you get if you get the vaccine.
Thank you, Regis. That's a very clever approach. Fiona, that's not been my interpretation of what's happened in Australia. There's been a lot of discussion about specific vaccines, so it'd be great to have your comments.
Yeah, I mean, I think the situation in Australia has been quite different to Canada in some ways, and so one of it is that there's been a focus on the differences between the vaccines and who should be taking each one, and there's definitely much more support for the Pfizer and Moderna vaccines than there is for AstraZeneca. And we've also had the issue in Australia that we haven't had enough supply. And so there's a real sense that there hasn't really been a big vaccination promotion campaign because the government didn't actually want us to be keen to be vaccinated, because then this lack of supply would become even more evident. But in the current outbreak that we're having at the moment in Sydney, there has been a bit of a shift, I think, and a lot of commentary saying things like the best vaccine is the one that you can get access to right now. And there has been a bit of a shift, probably not enough, but a bit of a shift towards people accepting vaccination appointments for AstraZeneca that are available now rather than having to wait till late October, November to get the Pfizer vaccine.
Thank you, Fiona. Hanali, would you care to comment on the differences in hesitancy between the different vaccines?
Yeah, so there's definitely a difference in terms of vaccine hesitancy. And what in South Africa, when we faced the COVID-19 pandemic, we really hoped that the COVID-19 vaccine would then actually reduce vaccine hesitancy, but it had the opposite effect. Although vaccine hesitancy has come down over the last couple of months, but I think that it's all been fueled by the initial conspiracy theories. So it was first the conspiracy theories about the disease, and then it was just now being used by people to scare people about the COVID-19 vaccines. So also in terms of the different vaccines, so in South Africa we are using the J&J and the Pfizer vaccine. So when the J&J was paused, then so people are still having a lot of doubts about the safety of the vaccine, and what also I think really contributed to vaccine hesitancy in South Africa, and it wasn't supposed to be like that, is the J&J vaccine was rolled out to healthcare workers at an early stage as part of a phase 3B study. So it was an implementation study, but people still today believe that clinical trials haven't been completed and they are guinea pigs, and these things are tested on them and so on. So that unfortunately has contributed also to vaccine hesitancy, but definitely a difference even if you compare it to the infant program vaccines. Thank you.
And would you like to comment as well in relation to that question?
Yes, yeah. So for our case, well, we just have one vaccine, J&J, so people don't have much of a choice. But yes, people are waiting for Pfizer and Moderna. which we don't know if and when they will come. But overall, there is to a certain degree, yes, there is some level of hesitancy and preference to the mRNA vaccines.
Thank you very much. There's another question in the chat about whether COVID-19 vaccines should be made essential with respect to, like they are for the flu vaccination. So should we mandate the use of vaccines, and should they be placed on the essential list from the WHO perspective? Regis, would you like to comment?
So as I mentioned in my presentation, it's really been mandated to healthcare providers, teachers. If you want to go to universities, if you want to go on the campus, the university is mandated. So it's not politically done globally. It's done in small sections. And then some provinces adopted the vaccine passport. So it is happening in some way. It is happening and it's making it compulsory, depending where or what you want to do.
And Fiona or Hanali, your rigid compulsory vaccination, should there be some sort of mandate, and should COVID-19 vaccinations be on the WHO list as essential?
Yeah.
I mean,
so
I think one of, oh, sorry, you can go first.
Sorry, go on, Fiona, go ahead.
I mean, I think one of the issues is that there's not enough supply. So, I mean, in countries where there's lots of supply, then I think these conversations can start to happen. But for a lot of places, there's just, you know, that point where we might even be actually getting enough vaccine to everyone hasn't even been reached yet, let alone doing that last step of mandating to bring everyone else on board.
And Mujahideen.
Yeah, so I was just coming from an African perspective, is the same, the question of availability and supply. I mean, if we are to mandate it, do we have enough supplies for all? But I think we can take the baby steps as have been taken. A certain group of people, for example, those who are traveling, or let's say those who work in certain areas, let's say healthcare workers, we can start targeting those, and in that way, maybe slowly make it mandatory. But as a nation or as a general, I think supply would be a big challenge.
Thank you. And Hanali.
Yes, yeah, exactly what my colleagues also said. So you can't mandate vaccines unless you have been able to provide access to everybody. So, I mean, in South Africa, I think we have only about just over 5 million people now being fully vaccinated. So we are way far from reaching, you know, the ideal proportions of people being vaccinated. And then, yeah, so you know, there has been some discussions, and I think you also need to consider what effect will it have when you mandate vaccination. You know, we have a very strong constitution in South Africa, so people have rights, and it's going to create a lot of problems. There are already people protesting. I mean, nobody has said that they will be mandatory vaccine, but they're already protesting about it. So I don't think it's really going to happen very soon. Thanks.
And leading on from this notion of supply and perhaps the cost associated with vaccines, there's a specific question for the country of Lebanon. What are your suggestions to overcome vaccine hesitancy in Lebanon, where the economic situation doesn't allow this? First, to conduct large-scale awareness campaigns, and second, to have access to the population, since they are considered as expensive products, and they come at some cost for the country and perhaps for the individual as well. So how do we manage this in a country such as Lebanon, which has experienced quite considerable disruptions to their system over recent times? Regis, Fiona?
I don't think I'm well placed to answer that question for many reasons. Like Canada has been privileged and been buying vaccine. We have more vaccine than we have people to vaccinate right now. It feels weird when I hear that you still don't have the vaccine in other countries. And everything has been sponsored by the government, meaning the vaccine, nobody pays for the vaccine. Pharmacists get $13 for every vaccine that they give. The doctor gets paid to phone the patient that did not get vaccinated. So it's a different environment that we have. So sorry, it feels anyway. It's a different environment. Sorry, not a good answer, but
it's a complicated question, and it really comes to this notion of equity and prioritization. And so a lot of the response has been at the national level rather than at the international level in this sense. And so we've heard some excellent presentations and strategies for dealing with vaccine hesitancy within countries, but how can we actually get greater international collaboration happening in this context? Hanali, from a national perspective in South Africa, is the international collaboration on the radar?
Yeah, well, in South Africa, actually, we also now have a lot of vaccines available. So compared to, at the start of the rollout, we didn't have a lot of vaccines being available, but we do have at the moment. So unfortunately now vaccine hesitancy is taking its toll. So we have seen, a huge sort of a drop in demand to an extent that the government has now opened up this last week from 18 years, upwards. So anybody. So the hope is now for the young ones to actually, do a lot of social mobilization and also get the elderly and those who don't have access to get to the sites to come and vaccinate. So, in terms of international collaboration, I don't really know. I think, with vaccine hesitancy, it's mostly, in many cases, it's very context specific. So I think you need to look at your situation and then try and implement, the best methods or ways to work against it. But I mean, obviously, we can always learn from one another, but you cannot compare, say, for instance, our situation with Canada or with Australia. But yeah, thank you.
Mujahid, can you comment on that in particular in your context in Tanzania? In particular, you mentioned the importance of the consideration of faith and beliefs in vaccine hesitancy, and so this was a little bit different to some of the other presentations, and I really like the way how you frame the importance of having key opinion leaders to disseminate messages. Of course, those messages disseminated could be both good and impartial or negative in this sense. So how do we manage this in your context? You're on mute at the moment.
Right. Yeah. So if I got you correctly, you're how do we increase access in terms of belief, right? So I think here is where the key religious leaders need to come in, because faith issues need to be tackled very delicately. They are personal beliefs, okay, that could be faith or otherwise, personal convictions. So those that are religiously based, I think religious leaders should come in and should address them so that the hesitancy should not be coming from the religious perspective. It's at the end of the day, it's the decision of the people whether they want to take it. But I believe the religion should not be a reason for not to take the vaccines, because we believe that all religions would say you have to do what is best for you. And for this case, the advice has to come from comes from the medical personnel who are all up for the vaccines. So I think the religious leaders have a role to play of addressing this. And we have had instances in our country where religious leaders are in fact telling people not to vaccinate. So that is something that should be completely avoided. Again, as I mentioned, the freedom of speech. So this is something that needs to be controlled. Yes, everybody has a right to speak, but it has to be in a very controlled and environment where we should not be creating more doubts into the minds of the people.
Thank you very much. Regis, please.
So we in the hotspot area, which was a lot of immigrants and a lot less paid worker, we basically went to churches. We had vaccination clinic within well, not within the church, but at the church location. And we encouraged a community leader. When I talked about community leader, I mean like the priest, whoever is a spokesperson, the pharmacist, the physicians, their family physician, they were publicly vaccinated and shared on social media. So we addressed this very early on because we understood that we believed there was going to be a significant factor altogether. So we went where the people were and make sure their leaders, priests, pharmacists, doctors, chief of police, whoever they trusted, would get vaccinated publicly.
Thank you very much. There's still a couple of other questions on the Q&A, but I'm mindful of the time now. And so I'd like to bring this session to a close. These additional Q&A questions will go to our speakers, and perhaps they can be answered over the coming days. So I just want to remind participants that there are further webinars which build on the content of the webinar here. So an upcoming webinar event is event 1.5, working together across systems to transform vaccination policy, working with others in our profession, with other disciplines and agencies to establish sustainable policies. In this webinar, there'll be discussion about intra and inter-professional alliances to ensure that we can work together to deliver areas of policy addressed in this series. Panelists must also discuss working together with other agencies and policymakers to establish sustainable policies on vaccine access and equity, including how pharmacy can be a force for good in supporting vaccinations for all health workers. Next slide, please. Everyone is invited to join the next event. You can register by scanning the QR code here, or visit events.fip.org or transformingvaccination.fip.org. So if you enjoyed the content of this webinar, there are certainly other webinars in the future related to this, building on some of the concepts we've discussed today. If you're interested in other topics, COVID-19 vaccination is certainly not the only topic, then please feel free to check out events.fip.org. Next slide, please. And of course, World Pharmacists Day is on the 25th of September. If you'd like to participate in the promotion of World Pharmacists Day, if you go to this website here, which is highlighted in blue, fip.org/World Pharmacists Day #PowerPoint, you can create a poster similar to the one listed on this slide here. Next slide, please. It's been my very great pleasure to chair this session today. I especially want to thank our excellent speakers for sharing their expertise so generously and answering the questions by bringing their specific expertise, and especially to the participants as well for joining in this webinar, asking some very good questions and comments, and for your overall participation. So thank you very much, everyone, and thanks to the FIP crew for making this such a well-run webinar. Good night, everyone, and hope to see you next time. Thank you very much.